Okay, so in this video, we are going to go over why I ultimately ended up choosing a robotic assisted surgery versus the open heart. Kind of sounds obvious, right? You'd rather do something more minimally invasive than getting your sternum cracked open. But let's go into more details as to what actually happens by doing one versus the other. So if I would have gone with the open heart surgery, I would have gotten cracked open, they would have done their thing on the valve, closed it. When they close it, they wire the sternum together, okay? And so what that leads to is what they're called sternal precautions. And so there's things that you can't do when it comes to your daily living following the surgery for some time. And some of that's like lifting. When you get out of bed, you're going to want to come up to the side. It's going to hurt if you cough. I mean, it hurt when I coughed my way too. You'll see them, they'll give them a pillow to kind of hold on to compress the sternum and the ribs when it goes on, so that when you cough, it doesn't expand and then pull on the tissue that just got operated on. When you compress it, it holds it there, and you cough and it holds it. So you don't have sternal precautions by going minimally invasive. The minimally invasive usually is a shorter hospital stay. So I was there, I had surgery on a Tuesday, and I left that Friday night. So that was what, Tuesday, Wednesday, Thursday, Friday, three and a half, okay? With the open heart surgery, usually the stay is 4 to 7 days is what they say, okay? So hospital stay is usually shorter, okay, right? This is not the case for everyone. I think you've got to make sure, but in general, this is what they see by doing the robotic versus the open heart, okay? If you do the open heart, you cannot drive for 4 weeks, okay? Because they don't want you to get in an accident and then you have a compromised sternum that's still healing, and then all of a sudden you crush your sternum against the steering wheel, all right? When it's vulnerable and it's not fully healed yet. For me, I was able to drive once I was off the narcotics at home and I felt normal. So it was probably about a week and a half-ish, 2 weeks before I was driving again. So usually you can drive sooner, okay, which is right big when it comes to work. If you're trying to get back to work and you can't drive and you have to drive to work, 3-4 weeks down the road, it's tough, right? What else I have? So lifting precautions. I think you have to understand this too when we get into this. Is when I went and saw my surgeon, he goes, one of the questions is, will I ever need surgery again, right? And he goes, in most cases, a heart valve repair in typical patients he sees, he never has to go back and do anything. And if there ever is a problem, it's usually not where he repaired, it's a different part of the valve that has issues. But he goes, you're about 10 to 20 years younger than the normal person, which worked to my benefit because I'm going to most likely heal quicker because I am younger. And I'm more active, probably stronger than a lot of people who get it. So you have to take that in effect with some things that my recovery might have been a little quicker compared to others when it comes to activity level. But I know other people who've had open heart surgery and they were hunting 4 weeks later. So right, individual basis, just know the factors. If you're older you are, usually the slowing process is slower. The younger you are, it's usually a little quicker. All right, if I would have gotten this, okay, I can't pull, I can't push, I can't lift. If I would have gotten cracked open, 10 pounds for the first, 8 weeks. So I have a restriction for 8 weeks that I can't lift, push, or pull more than 10 pounds because they don't want to put the pressure on the sternum here that is healing, because if you lift and pull, you're using your pec muscles here that attach right to the sternum. So that is a huge thing, especially for me as a physical therapist. I need to lift limbs, I need to provide manual therapy, I need to demonstrate exercises. 8 weeks of only lifting 10 pounds would make it very difficult to do my job. Now I could educate much and I could show with lighter weights and all that kind of stuff, no problem. But in general, probably make my job much tougher because limbs can be heavy, and I'd have to get good at explaining things versus showing things. And some people need a little bit of both or better with one thing. So it's that is a huge factor as to why I went minimally invasive, okay? recoveries are usually quicker. Okay, I'm out of the hospital quicker, and the restrictions. Now, even after 8 weeks, for an additional 6 weeks, the restriction only gets lifted 20 pounds. All right, and again, this might change between surgeons for the most part, but roughly, the restrictions for lifting and pushing and pulling are much more severe with the open heart sternotomy than it is with the robotic, and that was probably one of the bigger reasons in the quicker recovery as to why I chose the minimally invasive. Not being able to do 20 pounds for that long would be rough. And then for me, I'm an avid golfer. I wouldn't be able to probably swing a golf club based off what the surgeon would say for 12 weeks. Okay, I only had, with the minimally invasive, a 4-week restriction of not to be lifting anything. After 4 weeks, I started lifting weights and doing bands, just working my way up again, and I got back to work after 5 weeks. So significantly increased how fast I got back to work, which means I don't lose as much money and I'm not sitting around doing nothing, okay? That was huge for me. For some, it might mean a lot. For others, maybe not so much, but it's the aesthetics of the 2 surgeries, okay? So if I would've gotten this, I'm gonna have a huge scar right here the rest of my life. Now I have 4 decent sized scars over here from the different portal sites and chest tubes that were put in there. So to some it might matter, to others it's not, but to me it's a perk that I don't have a huge scar right here. I have these smaller ones over there, all right? Some other things that they have on their form that they gave me. So less time in the intensive care unit, which I was in. I got surgery in the morning. I got put in the ICU around, it was a 6-hour surgery. I was put in the ICU around 1 p.m., 2 p.m., and I left that next morning. So I was there for just under 24 hours. And that's just nice because ICU, there's a lot of beeping, there's a lot of machines you're hooked up to, it's just louder versus being on the floor where you just got a room to yourself for most places, at least in COVID times we did. More room to operate, and you're just not attached to as many different equipment. So that was a perk. I mean, cost-wise, ICU is more expensive as well when it gets into billing. Less time on the ventilator. So when you have the surgery, you're put on the ventilator. No matter which one you get, you're on the ventilator, okay? However, many times with the open heart, they will keep you on the ventilator until they get you to the ICU. In my case, what they try to do with the robotic is they took me off the ventilator in the operating room. Again, case-to-case basis. This is a cardiothoracic surgeon's job to figure this one out. This is not me. Just for me, I was taken off in the operating rooms when I woke up in the ICU. I was not on it, and I was never on it when I got to the ICU. So that's a big thing, quick, because we don't want to be on ventilator longer. We just get off quicker, get back. Okay, so I might overlap here because my camera died, and I apologize. So I think I was talking about ventilator. So it's just, we want to get off the ventilator quicker. Just don't want to be on as long. You want to just get back to breathing on your own with that. So that's a benefit. Usually they take you off in the OR or sooner in the ICU, okay? Smaller incisions. So instead of having a big one here, I have multiple small ones. I'll show you pictures later, but you'll see smaller incisions that I had for the areas for the camera to go in and the different parts of the robot, the arms of the robot. Faster healing, talked about. So I got you get back to work quicker. Restrictions are less. The driving restrictions are less. So you just get back to living your life much quicker because you're not waiting for a bone to heal. You're just waiting for muscle incisions between the ribs to heal. So the muscles have to heal after they are poked or not poked, but you know, they cut it open to get through. They say less pain, okay? So I've had different opinions on this one from the doctors that I worked with. One, a lot of them said, you know, you're going between the ribs, very sensitive area there. It's not comfortable, you know. With me, through the process, I wouldn't say it was horrible, the pain, okay? But I can't compare it ever to this because I haven't had that. So they say less pain by going robotic. I've heard other people say that actually the robotic one is more painful because you are going in between the ribs, in those muscles, when you're breathing, you feel it. Can't really tell you because I only did one, okay? For me, pain wasn't a huge issue throughout the process. It's actually, when I woke up in the ICU, it was pain back here, and I assume it was probably some position they had my arm jacked into for the surgery so they could get into that side, okay? Less time taking narcotics for pain. So if there's less pain, the odds are that you're less likely going to need to take them for longer. I was taking narcotics. I want to say the oxy that I was taking was maybe for a few days when I went home. And I was in the hospital. I was taking it the whole time. I went home for a few days, and I was probably taking it for maybe, got home Friday, 3 or 4 days after that. It was more these migraines that came. And I'll tell you about my post-op recovery. That was actually the biggest problem. It wasn't the pain for the most part. All right, faster return to normal activities. They say usually 2 to 3 weeks. So like again, I was living my normal life about a week and a half after. Like there wasn't much things that were holding me back. I didn't go back to work for 5 weeks because I had to build up my conditioning, and I had lifting restrictions for 4 weeks, so I couldn't do my job. But in general, just daily activities, walks, bathing, all that kind of stuff, easily. Once I got home, about a day or 2 after I got home, I was feeling pretty good with that. And then they say shorter hospital stay. So we already talked about that earlier, okay? So I think that's the reasons why I end up going with the minimally invasive heart surgery. The faster outcome of getting better or getting back quicker is the biggest things. There's some minor, less pain. I don't know. Narcotics, it makes sense, but those are the minor details for me. It was, I want to get back to work quicker. This gave me the best opportunity to do that. That's why I did it. And I didn't really want to have to crack a bone open because I just don't think that would be fun. Okay. So I'm going to, at the end of this video, I'm going to kind of just do it where I'm going to flip the camera over, and I'm just going to show you pictures of what the Da Vinci machine was the handout the Mayo Clinic gave me, of what the Da Vinci machine looks like, the areas that they put the holes in. And then the next video, we're going to just talk about day before surgery, what it was like the day of surgery, and my process of recovery. Okay?
Yeah, so let's just go over the anatomy of the heart quick. So when you look at the heart, we have a right atrium, we have a right ventricle, and then we have a left atrium and a left ventricle. Okay, the left ventricle will pump into the aorta, okay, and that brings the blood out to the body. The right ventricle will pump into the pulmonary region there, which will then go bring the blood that needs to get reoxygenated to the lungs. Blood goes to the lungs, gets reoxygenated, comes into the left atrium, and then left atrium dumps in the ventricle, ventricle shoots it out. Okay. In between all these different chambers, there's different valves. So this one has the tricuspid valve, and then the left ventricle and atrium has the mitral valve. And so the mitral valve is what I had repaired. What was happening is every time, so when the blood contracts, this valve should shut, making the pressure build up in here and shoots it that way. However, when it was contracting, this valve was actually kind of shooting back, and you can look at the image on that echocardiogram or little video clip I had. It was kind of opening up this way, which then when it contracted down here, the blood, some of the blood, not all of it, some of it was shooting back in here, meaning not all the blood that was in the ventricle was getting pushed into the body. So the heart and the body is smart, and it compensates. It goes, well, crap, I need to get more blood in here. So the ventricle then starts getting bigger to allow more blood in there to try to make up for the lack of blood that's getting pushed. So to make up for the blood that's getting pushed back. What can happen in the long term is if this keeps getting bigger and bigger, the muscle gets too stretched out and too weak that it can't contract and push enough blood. And that's where the ejection fraction goes down, the percentage of blood that leaves the ventricle to go to the body with each pump. That's your ejection fraction. That goes down to a point that it can't recover, and that's where you start getting heart failure, and that's what can lead to other cardiovascular things or problems such as like strokes down the road. So that's the anatomy. Now, let's look at this photo now. Okay, so this is where they go in with the robot. Okay, so I was on the table, and they bring the Da Vinci over, and I'll show you the Da Vinci coming up here, and they make these puncture holes through the ribs into the intercostal muscles to have the robot arms reach across. So this is the right side of the body all the way to the left side of the body to get to the heart to cut it open. So they have, I believe it was 3 of them, and then they also have I believe, a portal for the camera. So I believe I have 4 scars for the puncture holes they made there. Okay, so you can see this is what the Da Vinci looks like. I hope you guys can get a good idea, but this is the robot here, and they put it over the table, and then one of the surgeons, okay, so there's 2 surgeons during this operation. One is over by the table, and they are just, I think, positioning. I wasn't awake obviously during this, but I think they're positioning the robot in ways to make sure that the surgeon who's operating the Da Vinci over in the corner, so he's in there and he's just using 3 fingers, okay, to operate the different arms of that robot while it's going. They have a camera that they're looking through to be able to see what they're doing, and so they work together as a team to operate do that. So there's one in the corner actually operating the robot with their fingers, and then we have the other surgeon that's bedside that's helping the surgeon out and getting the robot in the proper positioning to do it. So here is what they're actually doing once they get to the heart. So I just showed you how they got to the heart, but once they get to the heart, what they do to fix the valve is they make this V cut. So there's an anterior and a posterior leaflet of the mitral valve, and there's 3 kind of compartments of it. There's 3 leaves. That middle leaf was my thing, and what they do is they go in and they make a V cut, okay, to open it, and then they pull it together and stitch it, okay. So they make a V. That's because that leaf has some extra stuff going on. It's long. They cut it out and then they pull it together and then they stitch it, and you can see the stitches here. And then they anchor it down with an annuloplasty band out here, okay. And that's why I have to take blood thinners right now. Still, I'm on baby aspirin, and then I was on Eliquis for 30 days, but I'll be on baby aspirin for 6 months. Is because of this foreign object that's in there. So they have you just on some blood thinners for that, so nothing coagulates. So that's what it looks like, what they're doing, what the heart looks like, what the machine looks like, and what they're where they go in with the ports, and then what it actually looks like on the valve and how they're fixing it to tighten it up so that there's no leaks. When there's extra access, that's where it kind of, when it contracts, that excess can go back into the mitral valve and let some blood sneak back into. Now they've tightened it so when it pumps, it goes, opens, lets it through, and during rest it opens, and when it contracts to push it forward to the aorta, it tightens up, and then no blood can go back. And after the surgery, they recheck it. They do another echocardiogram when they restart the heart, and they make sure that no blood's going back, and so mine was good. So that's what it looks like.
Thank you for watching this video. If you found this information useful or helpful, please subscribe to this channel. Just drag that mouse right over to the red box, click it so that you're notified the next time that I post a video. Again, thank you so much.